So I'm going to spend the next few minutes talking on green stick fractures. Most of you are pretty familiar with what it's all about. So just going through a few principles. So green stick fractures, essentially one side fails in tension and the other on compression. So in simple terms, one side breaks and the other side bends. We're talking about the two cortices. You can see some illustrations of it. One side bending and the other side breaking. Clinically, what you see is a bent forearm. What you don't appreciate is the degree of rotational deformity, because you're just focusing on the angulation, the bent forearm. You underestimate the degree of rotational deformity. I would put it to you that the rotational deformity is more important. It can occur in all combinations. One radius can break in as a green stick fracture. The other can be a complete fracture. It can be in isolation. But you always need to evaluate the proximal and distal radioulnar joint, especially in innocuous looking fractures, single bone fracture. You need to be doubly sure that the integrity of both proximal and distal joints are preserved. Here is a case which is a simple looking olecranon fracture, proximal ulnar fracture. You can see that the angulation is quite apparent, but what you may not appreciate if you're not looking for it is the alignment of the radius with the capitulum, and this is a Montegia. So there are limits of acceptable alignment, as you can see. The more proximal you go, the older you go, you want it to be near anatomic as possible. But in simple terms, for green stick fractures, if there is a clinical visible deformity, it needs reduction under anesthesia. So I take you through a few cases. So here is clearly a green stick fracture of both radius and ulna, junction of middle and lower third. And this is what we try to describe this as where the apex is, where the apex of the deformity is. And you can see, as you can see, it is a rotational component. When you fall an outstretched hand with the body weight going through it, the whole arm pivots around it, and it is a rotational injury, which is a supination injury in this case. And so you need to correct that deformity in addition to the angulation. So when you correct it, you need to make sure that your cast is well applied. I think there is a subsequent talk about plaster, so I won't go into that. Here is another case. This looks almost complete, but on the lateral view, it looks probably, it could be a green stick fracture there as well. Again, you see the apex of the deformity tells you what the mechanism of injury is. This is opposite to the other one. This is an apex dorsal angulation, so it is a pronation injury, and so you want to kind of reverse the mechanism. That's what it looks like. So you want to kind of put some emphasis in correcting the rotational deformity. Okay, in addition to the angulation automatically corrects. There is a lot of debate about whether you should be breaking the cortex. I don't think you need to make any special effort in breaking the cortex. If it breaks during the process, well and good. There is a risk of the fracture being made complete and unstable, potentially unstable, if you voluntarily kind of attempt to kind of break the cortex. But you should correct the deformity and try to get a well-molded cast. There are a few practical tips. Innocuous, these injuries may look very innocuous, but you need to kind of look at, again, I want to emphasize on the rotational malalignment. Angular malalignments are quite easily identified on both AP and lateral views, so it's useful to know something called a radial crossover sign. So it looks well aligned on both AP and lateral, but what you cannot comment on is rotational alignments. So you need to kind of use some surrogate kind of interpretive methods to kind of see whether there is any rotational, and this was described in 2012. What it does tell you is, like, if you look at the proximal in an AP view of the forearm with the distal humerus in AP profile. So this is evaluated with the humerus in AP, and you want to see what is the relationship of the proximal segment and the distal segment, depending on where the radius crosses the ulna. So in a pronated forearm, if the proximal fragment is pronated, it crosses proximally, and you would want the distal radius, you would be seeing it on the other side in full profile. Whereas if it crosses in the mid segment, that is a neutral position, and you would see both superimposed. Whereas in a supinated position, they do not cross over at all, and you see the radius on the same side as the ulna. So that tells you that it is in alignment. So here is an X-ray. You would see that because it's crossing over proximally, you see that the proximal fragment is pronated, but this is in neutral alignment. So there is some degree of rotational malalignment here. So that's what you need to be aware of, that this is proximal fragment is pronated and this is neutral alignment. Does it matter? It matters when, in certain situations. Here is a 7.5-year-old boy who underwent a straightforward reduction and alignment, reasonably well-looking cast. 1 week later, position maintained, out of plaster at 6 weeks, reasonable callus, not fully united, but went on to refracture at about 3 months. Okay? So what are the risk factors that you know in terms of what we know about refractures? It happens in just about 5%. It can be up to about 18 months. Location of the fracture matters. Age, in the younger children it happens. Green stick fractures are a risk because of residual deformity. So that's something which you need to kind of pay special emphasis to make sure that you get it in acceptable alignment. And you need to remember that you need to immobilize them fairly long, at least 6 to 8 weeks, and keep them off all forms of contact sports for at least 3 months. So in conclusion, I've tried to kind of give you a brief overview on what is the acceptable criteria, focusing on the rotational correction. Make sure that you look at the proximal and distal radial ulnar joints, some useful tips in terms of radial crossover sign, and beware of refractures. At least up to about a year since the injury, all of them would be refractures if they fractured again. Thank you.